welcome to this week's special episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm Jon, the Dental Guy. And, here we are back home. And I kind of wish I was in Arizona right now. This last week of weather has been sort of punishing down here in the South. And,
hit a low for December, 18 degrees.
I know. We were down at 12.
If you're in the Midwest, you're laughing at this right now.
I know. You're like, oh, it's so tough down there with your 12 degrees above zero.
Oh, man,
I know.
Jon.
I mean, but
I'm so cold right now. It's ridiculous, So like me, I'm all the time trying to seems like the whole time I've been on this podcast, I've been trying to lose weight. Jon and I are animate about staying healthy and that type of thing. But it seems like when I get to a certain threshold, Jon, like I walk around like an old man. I'm cold. It's like you lose the winter brown fat.
Yeah. No, there's
Jon,
a truth to that.
You're a pretty fit guy as well. You and I are runners. But man, dude, last week when I was running, Saturday, I was like, I got to get out and do a long one. I did a 5-miler, man. I about burnt my cheeks off, with cold weather.
Well, we had to, I got a story about that. So, kind of about that? Years ago, I was always in half marathon shape for about a good solid 2-3 years. I was that was my goal, was to run some half marathons, and I was doing pretty good. But I learned about myself over those few years, among many things, that I can't handle it running outside once it gets down below 30. 30 is my threshold. I'm weak in that way. I can do it.
Do you get on the treadmill?
Well, so this is what we had. This is what we did. My wife also, she can run. She doesn't love it, but she walks, and she walks religiously.
What wife likes to run that we've ever?
That's not a lot of them. Not as many. But then again, we're going to get some hate mail because I'm sure there's lots of wives out there that are listening to this who are like, probably could beat us down, completely destroy us.
865-544-8954. Are you a runner? And you're a woman?
Send us your turkey trot results. With proof. But anyway, so we broke down and bought a treadmill.
Love it.
And now we live in an old house built in 1890. And the thing about old houses is they weren't designed for things like treadmills. And what I mean by that is that the house is loud. Our house it creaks, it cracks, you walk around. Well, where we put the treadmill on our grand plan was the room directly below the bedroom. And when you walk on the treadmill, it's okay.
Yeah.
But I did not know that if you run on the treadmill, not only does the floor beneath me shake, the floor above me shakes, and the chandelier that's in the upstairs, it literally sounds like the roof's about to fall. So the other morning I used the treadmill for the first time that we had gotten, because it was below 30 outside and I'm weak. And I got on that thing, and about 2 minutes afterward, my wife comes down there and she's like, you got to stop. The kids are up, I'm up. It's 6:40 in the morning. They're all angry, and it was the treadmill. But yeah, running. Now we got to run out in Arizona recently, and that was nice. Wes even had a route ready. It was it was a grand time, man.
It's good. We like to run. Hey, 865-544-8954. But before we get to your text, how about this, Jon? A word from our sponsors.
That's right. And if you've listened to this show for any amount of time, that when we talk about things, when we talk about who sponsors our show, we only talk about things really and truly that we believe in, things that have made a difference in our own practice. And the Dental Crafters Network is definitely one of those things. This is a group we've worked with for years and years, and they really are our go-to on a day-to-day basis. Unlock the potential of one relationship with the Dental Crafters Network, where possibilities are truly infinite. As a family-owned, full-service dental laboratory, they collaborate closely with dentists to understand and meet their unique needs in today's ever-changing dental industry. Choose Dental Crafters Network, where your vision meets innovation. Visit dentalcrafters.net or call 472-8302. And don't forget to mention the dental guys to receive 10% off your first case. Thanks very much to the Dental Crafters Network.
And by Restorative Driven Implants. Restorativedrivenimplants.com. Head there right now to sign up for the next course. I know the spring course is limited seats as well as the fall. It's starting to fill up. It's a popular course. Why? U.S.-based surgical training, immediate extraction, immediate placement. We just talked about it with Jan Bublik in the last episode. Implant and risk it, right? Should you be placing immediate implants? We teach it at a Restorative Driven Implants, a proven protocol for immediates, a traumatic extraction technique, healed ridge placement, fully guided surgical placement of modern dental implants on patients here in the United States, over 60 hours of CE. It is the best value in incorporating implants into your practice and becoming astute at that. So head over to RestorativedDrivenImplants.com right now to sign up for the next course. Make sure you mention the dental guys. And by
Spear Education, we have partnered this year with Spear really because it's once again an organization we believe in. We have seen how it's personally impacted our own practices and how it's literally changed what we do every day. And the folks out at Spear wanted to show their appreciation for what the dental guys has been doing, as we've just kind of naturally been talking about them over the years. And they're offering 20% off of a treatment planning with confidence workshop if you just put in the code dental guys as you go to sign up. So head over to Spear, check out their workshops, check out their seminars. I promise it'll change your practice. And thanks to Spear for being a partner with the dental guys this year. And with that in mind, Wes, oh man, we went literally what we felt like was sort of back in time recently out to Spear Education and got the opportunity to bring our associate docs, if you've been listening, kind of following along with this, bring our new docs out with us to experience what it's all about. You know, what is this whole thing all about? And as we walked in there, we could remember our first time coming into this new environment and really being exposed to a different way of thinking. And man, Wes, as that first morning went by prior to this interview that we're going to play here in a couple of minutes, what did you see happening in that room? You know, like, it's interesting as Jeff and Greg are starting to talk about what's possible, how to think about cases. It's just interesting to look around the room, see the conversations, even to hear why different people were there, you know, as people kind of introduce themselves. You know, what were you kind of seeing? It's always interesting to hear like perspectives of because we hadn't really talked about this on purpose since we had that first morning.
Yeah, the average person out of school was around 9 years post-school, which, you know, there was a lot of younger people there. It's interesting. I don't want to really share yet because we're going to save that for the next episode, what our associates have brought back from this. But the initial reaction as you're looking around the room is you start to formulate some questions about like, well, why didn't I know this? And now that I know this, who can help me with this? And you start to ask questions about where in my community, my dental community, can I reach out to specialists, interdisciplinary team members, or even do I need to, now that I'm learning treatment planning or a diagnosis and etiology of certain things, if I don't have it, can I get the training to obtain it? And this conversation that we're having with Gregg Kinzer and Jeff Rouse was really next level. There were some tough things in here, and when we come back in a minute, we'll recap that just briefly at the end of the show, so hang in for that. So, you know, I feel like that this first morning and day, you know, really you start to formulate, like, what kind of team do I need to go back and I need to reach out to my specialists and start to ask questions, John?
Yeah, I think especially as, the teaching out there has evolved past just the way of thinking about things based upon, aesthetics, function, structure, and biology. But now we've added airway at the beginning of all of that. I think once you have that piece in your mind and you start to see how a lot of these cases get treated from the simple to the more advanced, you start to understand what type of skills are necessary. What type of team do you need to have? And I could see as people were watching these kind of first initial takes on some cases they were seeing, some things we were learning, that they were thinking, okay, I know now kind of what's possible, but I got to figure out who's going to do what, where's the team, including laboratories. I mean, everybody has to be able to somewhat speak the same language. And I think that's why it was really cool as we had this conversation with Gregg and Jeff, that you could tell that they've been doing a lot of thinking about that. They've been doing a lot of thinking about what does it take after you take this course? What does it get people to start to think? And they're already thinking ahead. So we really think you're going to enjoy this interview. And like Wes said, just stay after. We'll do a little recap about kind of what we heard and what we took from that. So without further ado, here we are with Gregg and Jeff.
Well, welcome back, Jeff and Gregg. That's your name, right, Jeff?
Yeah,
I mean, but like in the previous show, we were like, Gregg and Bob and all that. But it's good to be here on the Spear campus. Jon and I brought our associates out here, and already it's been good to see their lights turn on and them start to ask questions. I think, building on what we talked about the last show was we talked a little bit about how you come back from this and you start to see the need for orthodontics, surgical things like we talked about this morning, Gregg. And Jon and I really, have embraced that in our practice, an orthodontic first situation where you're looking at the teeth in the current position they're at, and you're looking at 8 and 9 in particular. And we want to talk a little bit about some things that happen when you do come into practice and you're seasoned at treatment planning and you're looking at 8 and 9. You see the need for tooth movement and you see what it could do. But a patient maybe doesn't commit to that particular plan, but they still want some dentistry done. They want their teeth to look better. They want things to look better. Where are you willing to accept maybe that compromise? Give me some of those things. Gregg, I'll start with you. You're shaking your head.
I've never had a patient that did that, so I don't know.
Yeah, everybody says yes. In Jeff's world.
It's a wonderful question, and I think it's a dilemma that dentists encounter. They need to know what the ideal is. So that's the starting point. I think our patients require us to give them the ideal plan. The challenge then is, how much am I willing to compromise? What does that look like? And it's almost like, well, what does a compromise look like where you overstepped your own comfort zone, right? Mm-hmm. Like if you've ever done something, you go, do not tell any other person who did this, right? You probably overcompromised, right? So that's, every dentist has their own line for that. But I would look at it as, am I over having to over prep the tooth? Am I having to devitalize the tooth to do it? And I go, that if I do, not going to work. Do I increase my risk occlusally or functionally? Meaning that there's a high risk that it's going to break or cause problems. Then I say that's a line. I'm not going to cross that line. I think one of the things that we do well here at Spear is you need to know the implications if you're unable to do the ideal of what that means, which means you need the big picture. So you can know, all right, I don't have to do ortho. I could probably move the tissue with surgery and I could do some additive, but how much can I do? Mm-hmm. What's the occlusion need to be? I can't make a central incisal edge 4 millimeters thick. Like that's crazy. So you need to know the ideal and you need to know what am I able to bend on and what's the risks of doing so. And I think I had somebody say once that, Spear teaches you how to do it the right way, but they also teach you when things go wrong, which they will. Inevitably, something doesn't go your way. You need to be able to figure out how to get out of it and know that this is the way to think my way out of the problem and get on the other side. It goes to the same question. how do I think my way around it so I don't get into that problem?
Right.
It's a really good question, and it's a challenging one because dentists need a lot of knowledge to know what that level is.
That's a problem, is the knowledge. Because John and I, we've been in it long enough. You have too, and is that we know some of these solutions for the no, I don't want to do that, and then know what your limits are.
Yeah, let me get to and Jeff, I'd like for you to give you like an actual scenario that we see commonly. We talk about this as we will be talking about at this Treatment Planning with Confidence workshop, cases where we have maybe a deeper bite, we have some supereruption, compensatory supereruption with wear. So we see potentially a lower occlusal plane where these lower anteriors have supererupted. And so gingival levels on the upper, maybe we have that discussion, but let's just focus on the lower for a moment. Patient says, I'm not going to do orthodontics if that's the line they draw. And we know that we have other options to restore the lower in order to put the gingival levels where they need to be, maybe put the incisal edges where they need to be that are not orthodontic options. Mm-hmm. For instance, you kind of touched on it, do we do elective endo, post-cores, crown lengthening? What about extracting teeth if they're severely worn and doing the implant bridge? These are obviously options, but are these things that, are we pushing too hard? Are we pushing too far? What are some of the limits that we run into when patients, don't give us maybe the options, or do we just pass on that case? Kind of how do you approach those things?
I always go back to something that Gregg has said, that was really impactful to my thought processes in treatment planning, which was when you say no to one thing, you're saying yes to another. And so if you approach it that way with the patient, if you're saying no to ortho, then you're saying yes to these issues. If you go through the thought process there, which I've done, instead you take supererupted teeth that are worn, and they won't do ortho, which would be an easy resolution, push the teeth down and restore them with veneers because they've created the space essentially and the prep already. If they say no to that, then you go, okay, well, we can do crown lengthening, we can cut the teeth down, we're probably going to have to do some endo on these teeth. There's a lot of complications that come with that. Mm-hmm. And so they need to understand the ramifications of making that particular decision. They also have to know the ramifications of not doing anything at all and continuing along the path that they're at, and what limitations that places on my abilities to work on the upper teeth, mm-hmm. which are also, in your example, worn and erupted and changed in position as well. So I think one of the important things that we teach in this course is, two things. One is only really present one treatment plan at a time because people get confused if you start providing a lot of options. Mm-hmm. So you're right. You have to have enough knowledge to be able to know all the options and be able to see beyond just restorative dentistry, which is what you learned in dental school, to know how to use your specialist correctly. Because you all have essentially turned yourself into prosthodontists by learning what all the other specialties can do for you. Mm-hmm. Once you have that level of knowledge, then present the ideal and then work your way down from there, showing this is ideal, here's the reason it's ideal. Mm-hmm. Here's, if you say no, and I can't convince you to do it, then okay, here's another way we can do it. Getting down to the final one, which is I'm not willing to do that. And my answer for them always is somebody will be able to do this in town. It's just not going to be me. Mm-hmm. I'm not willing to take that kind of risk. Mm-hmm. The other thing that we do in this course is that I think your new associates will have difficulty with, if they're like every other young dentist, is how to present the information to patients.
Yeah.
Right? So now we're teaching you the knowledge, and we're giving you ideas through our decision trees that your associates were introduced to this morning about how to think through a case. But at the end of it, you still have to get the patient to agree to do it. And how does that case presentation look? How do you work with specialists and all the rest? So I think we do a way better job than we ever have in assisting people in gaining the confidence to actually present the ideal plan. And then what do I do next? Mm-hmm. Because Gregg and I both are in private practice, and I jokingly said no one ever said no to me, mm-hmm. but yeah, they do it all the time. So you have to figure out how to do that. It came out.
There's certainly a limitation to maybe even where you're located in the country. and maybe even your own skill set to what you're able to perform specialty to get to some of these results. We're not just restorative general dentists sometimes. Sometimes we're the surgeon. Sometimes we're the orthodontist. And we do have those skill sets that we go out and find. One of the things that I think comes from this is more questions, because now you open the mind up. Okay, now that I know the etiology and the diagnosis, whoa, he just talked about, and you didn't mention it this morning because it's a next level question, is the difference between functional crown lengthening and aesthetic crown lengthening. You talked briefly about that.
I didn't want to steal Jeff's thunder this afternoon.
Right. But see, that's the thing, is that I think that's the interesting thing about the layered approach of learning. And I appreciate the evolution of this course. I mean, we took it almost 10 years ago, and I appreciate that layered learning approach. It was a little different before. Jon and I've talked about that this morning, and we recognized that, completing the core curriculum, you see the continuity. It's so important. But like, you talk about a patient that, they disagree with ortho, and you're like, well, that means you're going to have to do this. This course gives you that, okay? But then the problem is like, okay, how do I do that? And that's the question that comes up next. I mean, when we talk about, over-erupted lower teeth, and we say we don't want them any higher than 3 millimeters or so, at 60 years old, and you're looking at these things and you're thinking, the only option I've got here, because the papilla are sitting at the top of the lip, is to basically either impact those with TADs, because we have that in our mind, or basically do a massive amount of alveoloplasty and take them out.
Yeah, right.
And then we start thinking about, well, how many do we take out? Well, I mean, I had an oral surgeon call me the other day, and he stopped and he had a pause, and I love the pause whenever they call a restorative dentist. And he said, what do you want me to do here? Okay? And I appreciate that, because he ran out options. Do I take out 23 through 26? And I said, wait, right? Talk about the pause for a minute that happens in the brain whenever you get to this learning approach, and then you're like, is that enough, or do I need to know more?
Yeah, it's we're talking a lot about lower anteriors, and I think it's a problem that dentists often face, and most people don't talk about lower anteriors. They talk about upper anteriors.
I think it's one of the most important things.
Jeff and I, when Jeff and I ran the Warren Dentition seminar, he brought in a section, and I've continued it, so it's better now. But it was on managing worn lower anteriors. And it's a brilliant section that he put together, because it enables you to look at all, like, here's ortho, here's crown lengthening, which is rare that you can do it. Here's some options. And you get to the point where you go, well, if you're not going to be able to do this, then maybe the best option is to take them out.
Right.
Because, trying to do a bridge on lower anteriors, that's crazy, because then you divide, like, to get them to draw, and then you grab the canines, you got to get everything to draw. Yep. There's nothing left.
Yep.
Right. So it was a really nice section, and it only lives in that one seminar. And it was never lived anywhere at Spears. So it was a really nice addition.
Yeah, because we run into these questions every single time.
We focus on the upper anteriors, but the lower anteriors typically are the ones that they're wearing against. They're also a problem. Yeah. And we really aren't talking about that.
Let's talk about, in the same kind of vein there, with...
Can I jump in real quick?
Oh, of course, yeah.
There was one thing that you said that struck me, and it was, you said where you're at in doing this. You may be the orthodontist. And that actually is something that is ignored quite often, because you're going to have to go home and form an interdisciplinary team, right? And y'all are in a different position as far as access to care than I am in San Antonio than he is in Seattle. We all have our strengths and weaknesses. And interestingly, it just went through my head, because when you start thinking about treatment planning and the way that you go through it, you're going to play to the strongest members of your community. So I believe, have some of the strongest orthodontists in the country in San Antonio, Texas right now. And so my mind immediately says orthodontic solutions, right? Gregg works with one of the best periodontists in the world. So he sees periodontal solutions faster than I do. So
that's a great point.
When you work your way through decision trees in answering, part of it is also going to be what specialties.
Let's
are
call
you
it
working
weighted specialties, like where weighted strengths and
with? You want
treatment plan.
orthodontics to be your strength.
You do.
Yeah.
I think that's
needs most, and this is a very good point, because the cases that challenge clinicians are typically wear patients.
Mm-hmm.
And even if they're not a wear patient, most adult patients who need restorative probably can benefit from doing ortho.
Mm-hmm.
Yep.
It might mean that I have to restore fewer teeth. It might mean that I can restore them more additively or just completely additively. Then the question becomes like, all right, if they don't do the ortho, can I still treat it? Is that still an option? And I think a lot of patients it is. If you don't have the orthodontic support, which I agree is the main support you need for a lot of the airway pieces, for the health piece, the orthodontist and the oral surgeon, those are your main people. So that should be a top priority, is to see if you can find those people. But now a lot of restorative dentists are doing aligners themselves, and I think that's fantastic. I hear from the orthodontist, oh, we're not going to have a profession after a while. It's like, no, you are, because there's more comprehensive, complex ortho that needs your skills.
That's right.
Yep.
But beneficial wise, it makes sense for a restorative dentist, especially in a small town. I'm going to do my own training, my own aligner therapy, and I can actually help way more patients and do way less dentistry or way less invasive dentistry. So if you don't have that person, you can become that person.
Right.
depending on
Well,
where
and
you
that's
are.
exactly where I was going to go, is when we talk about the orthodontist and, treatment modalities that we have now, I think that's where it's really, we're finding that's where we are having to push the hardest to, and it's a different mindset. Like you say, you can either look at it as they're taking my business, or you could look at it as let's do some things that only we can do, because that stuff is out there. But it's interesting, just in the last, I feel like maybe even year or two, have there been places where orthodontists can go and actually learn these advanced techniques in a systematic way. Up until then, it was like you would go and you could see there was like 4 people that could do this,
Right.
in our country. And that would be, and they weren't teaching, some of them because they're busy, some of them because they're just, they're doing their thing. And just now are we getting to where somebody can go learn how to do SFOT surgery, or can learn how to do a custom RP with an actual curriculum, not just like watching over the shoulder. And maybe speak to that. I know, Jeff, we've talked a lot about this. Where are we at that point now of like maybe like almost like a super specialization in ortho, of like the kind of person who wants to do what we're learning sort of to do here from a restorative standpoint, where orthodontists or oral surgeons could say, I'm going to exit the world of like the drag of the day, and I'm going to get into like, I want to treat to like ultimate health. Are we, because I feel like we have places you can go and actually learn this now.
Yeah, no. And we were both laughing, because your idea of providing a location for advanced training makes sense, because they're having to do it piecemeal right now.
Yep.
A lot of the people that come and watch the cases that we're doing, especially by the time you get to the advanced course that we treat, you see at the level that our support, you go, well, how in the heck am I going to get that?
Yep.
It would be so nice to be able to say, go to this place and get this advanced training as a specialist.
Yeah, a true curriculum. Because I think Jeff's right. You're right in that there are places where you can learn. I can learn how to do a MARPI, and I can.
Mm-hmm.
But imagine a world where all that lives under one roof, and it has a common thought process and treatment planning process that is interdisciplinary based, that brings it all in and brings it all together.
I'm getting chills.
That's
yeah,
what
that'd be
we did.
amazing.
That's the ideal.
As pros residents, that's what we did.
Mm-hmm.
Is we had the meetings that we had weren't just with the prosthodontist in our 3 years in there. It was also the orthodontist, the periodontist, the oral surgeons. We all met together and presented cases together and talked about cases. So imagine, if everyone was training at the same center, learning the same information, how much more integrated the care would be.
Yeah.
So that's sort of an ultimate dream to make that happen. What do you do up until that point? You're right. There are some new courses that are around the country in different locations for people to learn and advance their skills. I just went over to an orthodontist down the road from me that's opening up his own practice from scratch, and he just built it out. And he's got bays that are set aside for advanced cases. So things that he's going to have, it's usually adults. It's things that are going to take more time. He's going to have rooms where he can place MARPs and all the rest. Yeah. And it's not just happening in the Bay where, an 8-year-old's having to watch a MARP get placed. Right. Mm-hmm. So he's got it all set aside, and he's got rooms that are built around this idea of creating the ultimate care. So.
But I mean, that's a good point. And here's the challenge that dentists have when they learn, let's say, the treatment plan with competence, the FGTP process. You got to change the way you see patients. You got to change your timing. You got to change the structure of it. Yep. And orthodontists will need to do that as well, because if your goal is to get 40, 50, 60 patients in your practice a day, that's your turnover. You can't do that if you're doing these like more advanced ortho techniques. I need to take more time. I need to have other rooms. Yep. Like to have a center that actually lays out, as we're trying to do for the restorative dentist, that criteria would be super beneficial, because you don't have to reinvent the wheel if somebody's already put it into their practice and they know here's the timing that it's going to typically take. Here's a fee structure that I think compared to my base fees for ortho, like all of those pieces have to be thought of together. It's not just the technique piece.
Yeah. Right. Well, and up until just, again, a couple of years ago, we didn't even have the data, really. I mean, we just now finally see the data showing up on some of these techniques where it's we can understand the fee structure better now. We understand the time better, and we have the data. So it seems like it's the rabbit hole we go down when we come here and we talk about these cases, and you show, especially like you say in the more advanced courses, what's possible. You start to have to go back to and figure out like how much can we do in our practices, how much, where do we have to send people, which we're not opposed to doing. But in the end, it's like if you have somebody that's excited about this, you want to be able to send them somewhere. You want to say, hey, here's our next step with this. Yeah. And it really isn't so much the restorative doc that becomes the limitation. It becomes the team, a limitation.
Yeah, no,
go ahead. You touched on a point that I think is kind of crucial, that let's say you're bringing this into your practice and you're recommending some of this more comprehensive care and some of these advanced ortho or surgical techniques. If you're trying to work out the kinks as you're going through it, it's very disruptive for the patient.
Absolutely.
And Jeff talks about this when we did interactive, is if patients are jazzed, like they're ready, I'm ready to go. And now it's 3 months before I can figure out how to find out who's going to see them. Then all of a sudden they have, I got to fix the car and the refrigerator went out. And all of a sudden there's things that take priority and the dentistry now goes away.
Yep.
So having systems in place to enable you to do your piece and move them down the system, you got to catch, while the iron is hot, you got to
catch it.
You got to catch it.
Well, your study clubs are a great way of.
Mm-hmm. I think it is.
Because you can talk about the case in the study club, and you already have the description.
Yeah.
I mean, one of the big things with Spear study clubs is you're able to look at cases that we present and talk about those cases, but it goes beyond just the case on the screen. It's just getting saying, well, if I send them over to you, I can't have them sitting around for 3 months. We need to get an exam. You don't need, all I need you to see is this. Can you do this? That's all I need, right?
Well, and it's a vision of like, you have to be, many times the study clubs are organized by the specialists, is what we've seen over the years, and for good reasons. Part of it is truly like to learn, and part of it is because it's great for business as well. Like it helps to drive business, but we've got to be able to be humble about what we don't know. Like the business side of it will come if we're able to have the vision, but actually what can we do and what can't we do? You touched on it earlier, like you get to see what your specialists are actually capable of when you have study clubs and you show cases and you're like, well, here's the regenerative result we can get from root coverage. Here's my case that I actually did. And if you're like, well, that's actually not that great, then, you're like, got it, like that helps you to calibrate what's possible when you send your patient over there. But I think that if we don't have those real kind of tough discussions though, of like, hey, how do we get to that level? Because maybe 5 years ago, it was just a few people that were maybe getting these results. Now it's like a lot of people are getting these results. It's more predictable. We can actually achieve these things, but it's not easy. It's just a little bit more predictable now.
One of the other weaknesses of study clubs is that the model the original model was mostly surgeons running the study clubs.
Absolutely.
Good
And
point.
so the original model was developed at a point in time where surgery was the key component of fixing these cases. If there was an issue, you did surgery, you did functional or aesthetic crown lengthening, you put in implants, you did whatever. And the model needs to change where the orthodontist is playing a larger role.
Well, I think the model needs to change in that, and you stated it, let's say the Spear Study Club, the case that you're watching, the module is just a conversation piece. That's all it is. So it needs the study club system. It needs a facilitator and a moderator. It needs to have somebody that is the prosthodontist in the room, or doesn't matter, not a prosthodontist.
It could be a restorative.
It could be a restorative dentist.
Restorative dentist.
It could be an orthodontist, but somebody that knows the bigger picture and is able to actually have discussions that call on others.
Yeah.
Because you can't have one person running it. You need to be able to. The best study clubs are the ones that are interactive with everybody participating.
I think really, honestly, the frustration with study clubs have been that there is a lack of knowledge from the top down. And Jon and I have been frustrated with it for years. It's why we haven't been active proponents of study clubs in our own community. I lost a dental giant to passing away of cancer, and he was a dental giant, and he started a Spear Study Club, and then it just went, when he died, it went away because the orthodontist that was there at the time didn't have the knowledge to carry the room. And so then what happens is like the community of care drives what the knowledge needs to be for the orthodontist. So if you have a restorative doctor or a prosthodontist, okay, that has a level of knowledge that can answer and field questions, because once you get done with those discussions, and I've been in it, and you don't have someone there that can call people out in a great way, in a conflicting way that's constructive,
right? Yep.
Then it's a problem. And here's where we were successful in Knoxville in creating a airway club. And it's not associated with Spear in any way. It should be. I actually was thinking about that as you were lecturing this morning, is how could I go to the next level with this? Is I, as a restorative doctor who understood what he and other people here taught me, approached specialists with knowledge they didn't have. A pediatric ENT, an ear, nose, and throat doctor, an adult ENT, an orthodontist. And what I did is I said, let me challenge you on what you're saying. And I knew enough and had read enough, and you had given me enough knowledge, and you as well, and other members here, that I was able to go with them, and I confounded their mind.
But why is it, though, that the restorative docs are driving this? Why isn't ortho taking charge of that? Because I don't see that happening. I know that this is not a problem with their academy, or it's not a problem that I see,
Even
or
with
the literature, or the meetings. But yet, and I know that's a rabbit hole as well, and I'm not. But like, why we find that the level of dentistry seems to be determined in every place that we've ever been, and I think you would agree with this, by the amount the restorative docs are asking for, like, hey, I need this, I need more of this, rather than it being the specialist pushing down that knowledge. And I don't know, that might have changed a bit over the years. What do you guys think about that? Like, do you feel like that's...
You're going to get us into trouble with orthodontists.
I think it's
what's going to happen.
Well, I mean...
they need to be called out.
Okay, but you're right. It is restoratively pushed, typically. And I can only... It's okay. So let me finish.
In the right situation, it's restorative.
Let me finish. Because I'm going to piss some people off now. Orthodontists do really well at what they do. I'm not going to say it's easy, but lining up teeth for children, especially with aligners, it's a money producer. You can get in 40, 50 patients, and it's pretty slick. When you have patients who require adult therapy that need some of these other procedures, it takes time, and it's hard, and it takes multiple appointments, and you got to schedule differently. And you go, why do I want to do that? If I'm cranking it out, why do I want to do that? Now, it's orthodontic based, because there are orthodontists that go, wow, we can do that. And the restorative dentist might bring it to their attention, or maybe they see it at one of their academy meetings and they go, I want to do that. I want to help my patients in a different way. But it's not all orthodontists, I would say. Not all want to do that. So that's why it's challenging to find the ones that it's hard work.
It very much so. I use this as an anecdote. It definitely is. But, I remember coming back from FGTP. One of my best friends had edgeware 6 through 11, 22 through 27. Okay. Ruled out airway. Okay. Airway was not a problem. And I'm like, there's lack of posterior wear. We know what we need to do. We need to increase the overjet, decrease the overbite, and then add incisal edge composites, and then eventually do crowns or veneers, whatever. Okay. I go to my orthodontist who was seasoned, 30 years in practice. He said, every case, Wes, I've done like this, like it just doesn't work, and the teeth, they break and all this kind of thing. And I'm thinking, no, let me show you. And I said that. I said, no. He's like, I just don't think it's successful. And I said, okay. You know what I did? I went and I got some training by an orthodontist, and I put the freaking brackets on myself, And you know what's frustrating about that, Jeff? I didn't really want to do that. And when I went to this high-level orthodontist and I said, can this be done? He said, absolutely. Did it for my entire career. He was a thought leader. And if I mentioned his name, you probably might know him. But he said, I will help you get that done. And I'll say it wasn't as good in my hands because I didn't have the reps as it would have been in a specialist hands. And we're getting driven down this path.
Yeah, I don't want to be that guy.
I don't want to.
I
mean, honestly.
I mean, I really don't. But it's almost like we're getting like banging our head against the wall so much about it that we feel like is that going to be how it kind of turns, And we don't want it to turn that way because we're such believers in the interdisciplinary approach. But I feel like it's a hard turn that way that we're feeling more. It's not about being the super GP who's just trying to crank out as much money as possible. That's one approach, but this is different. It's a different approach.
I think, and I would hope that the new generation of orthodontists are coming into ortho because they see the benefit from a health standpoint. They see the things that can really, like the things that are out of the norm of the regular ortho curriculum, and they go, I want to do that. So maybe I would hope that the new generations that are coming out are. Am I wrong?
I think you're wrong.
It's a
Jeff,
hope.
I think you're wrong, but I want to hear what Jeff says.
He's been strangely quiet, but
I hope they would.
It's personally dependent on who that person is.
Well, I think I've seen a couple of them, like Ray Caesar, right? Ray is one example of that, like young guy, but he's with Tito, right? I mean, so like he's got somebody that's bringing that.
But Courtney just went back to ortho. She's graduated 2 years ago and still. At her program, there's
no. I'm not saying that the programs are going to implement it. I don't know.
So they still have.
Yeah, that's too much to ask.
Yes,
they're not going to come out of school.
But you have to have the motive. The clinician has to be the motivator to be able to say, "I want to do this. Let me learn where I can do it. It's not in my program. We're not doing that yet, but I want to do it." So then this goes back to our idea of having our interdisciplinary training the specialists idea.
Well. I think,
whoa.
Okay. Well, that's what we didn't expect you to say that, but we hoped you'd say that. Mm-hmm. That's pretty awesome. I think that if we can take something from the discussion, and I know we've got to get back to the main event today, but it's really, we see that we're tracking along the same like things that you're feeling or the same things we're feeling when we talk to people who are, especially restorative docs that we talk a lot to, who are kind of in the same boat and they feel the need for this stuff, and it's exciting that you guys are getting to, be around the smartest people in the room as you all are with these folks all the time and get to see who's interested in this. Mm-hmm. And it sounds like maybe there's some interest in that. Like that could be something that could really push us forward.
It would be so much easier when we spark interest in the orthodontist or whoever it is, surgeon, whoever it happens to be, if we could immediately say, go to this.
Yep.
Take this.
Here's the path.
And then by the end of that, you'll have the knowledge you need to evolve your practice to whatever level you want to be, which is exactly what we say to young restorative docs.
Yeah.
Or not even young, seasoned restorative docs that want to evolve their practice from where it is to a vision of something greater. And we tell them, come through this curriculum. By the end of our core curriculum here, you will have the ability to do any fixed case that comes into your practice.
You guys are functioning as prosthodontists.
Well, we appreciate that.
And the questions that you ask and the dilemmas that you're encountering illustrate that. Because if you didn't have that knowledge level, these would not even be a problem to you because you're like, I don't even see it. I don't see it as an issue.
And I think as we kind of close out this segment, it's cool to be able to be kind of on the other side of that in a way. And then that's why we're such believers in what's happening here on today, like day one for a lot of these folks, like having their minds sort of blown in a way or opened or, going down these decision trees and because it does make you have to kind of ask the next question and the next question and the next question. At some point, you feel like I feel comfortable with the things that I should be comfortable with.
Mm-hmm.
And that's truly like what we've been able to achieve through this and then implement into our practices.
Love it.
And so we appreciate you guys just talking with us and the passion that you bring to all that. And if you guys are watching this or listening to this, we're going to be doing another follow-up with Wes and I about what did our associates actually get from these couple of days? Like what did they think they were going to get? And what did they actually get? Because I find that it's often very different, like not in a bad way, but
interesting.
Well, we had a great conversation over breakfast and dinner last night, and I just blanketed without any interruption, just said, what do you expect to get out of this?
Mm-hmm.
It was interesting. I won't share that with us here
fill
today.
you in.
We'll fill you in on that. So thank you guys
Can't wait to
so
hear
much, and we'll look forward to more this weekend. Thank you.
Yeah. Appreciate you guys being here.
Yeah, absolutely.
Jon, an incredible interview. In some ways, we were not easy on specialists and even on Gregg and Jeff, and you can actually feel it in the conversation. There's points in this conversation, Jon. I want to talk a little bit about where specialists are at today. I mean, if they're the ones that are supposed to be leading study clubs, or in some cases, a person that has a certain aptitude for being able to control the conversation, where are specialists getting training beyond that of their residency programs and things like that? There is a lack of education right now when it comes to some of these things for restorative dentists. And really, restorative dentistry is driving a lot of these conversations with our patients. What's the problem?
Well, I think when we get out of school, because you think about how you did treatment planning when you were in dental school, and you were the lowly GP, really. You were the lowly GP as a student who would go to each specialty and say, hey, I need to have a pros consult, I need to have a oral surgery consult, whatever. And all of these people would tell you what they think the plan should be. And you looked at them as like, hey, if this person says that this is what I'm supposed to do, or what I can't do, or what's not possible, you would say, hey, I'm going to frame my treatment plan based upon what they tell me is possible. And I think when you get out of school, you think that way. And now we've come to understand, as we see what actually is possible, and I don't mean just in someone's hands, but in the data and the literature, you see what is truly possible in an interdisciplinary approach. And you realize that oftentimes your specialist is not necessarily going to have the ability or even sometimes the knowledge that's necessary to tell you what should happen. So you can't, so it's sad on one hand, because now we realize that really the general dentist, often the restorative dentist, is the one that has to be the one who sort of frames what's possible. Mm-hmm. But really where we want to get to is back to where we were in dental school, back to where, like, I want to go to my orthodontist and say, all right, here's this patient, here's kind of what I'm thinking. What do you think about this? And my orthodontist goes, hey, let me just tell you where you're wrong. And let me give you 3 citations, and let me show you the paper and then let me show you some cases I've done. And let me show you what, I went to this conference last year, and here's the newest thought on this. Yeah. And, and then each specialty to really push the conversation forward. But in order to do that, first off, I think we need to realize as restorative dentists, we need to be asking our specialists for a higher level. We need to have higher expectations. But then to be fair to them, we need to be seeing better training from not only the residency level, but also the post-residency training that gets people to think toward a team approach instead of just sort of, I think they get frustrated too, Wes, with us.
Yeah, I agree. I think that there's probably as much frustration, if not more, towards the restorative dentist than there is maybe towards the specialist from our end. And it's good that you bring that up because the really, and we said this in the interview, is who's driving this treatment is not typically the specialist. You're not getting your cases from your orthodontist and saying, hey, I've decreased the overjet, I've decreased the overjet, I've increased the overbite, or whatever, that needed to be done. I need you to do some transitional bonding on this case. No, you're not. You're not getting that type of referral typically, unless you've been working with somebody for a very long time. So, I challenge you, and some of you think like, well, is this different than dental school treatment planning? If you're in dental school right now and you're thinking like, how is this different than me going and getting checks off at the periodontist and going and getting checks off at operative dentistry and then going over and talking to the removable department, and how is this different than that? Because that seems interdisciplinary. Well, it is different than that. You have more of a holistic view on the patient and the outcome that you're trying to achieve, which is health and putting the teeth in the right place. And we've talked about this in previous episode about orthodontics first. And for us, the struggle typically is finding an excellent orthodontist. And in some cases, you might have to go get training to become an orthodontist. And I think it's going to be interesting to see what Spear does here. Because if they embrace the specialist and some specialist training, it could be a next level, in my opinion, possibly one of the greatest moves in postgraduate education that we've seen, because there's nobody putting it all together right now, Jon.
Yeah, I think that what we hope, I think both of us hope that that the future can become more, instead of just even the dental school approach of going to each say you go to this clinic, the pros clinic or the oral surgery clinic or whatever, that's still not everybody at the same table.
No.
Or even the same Zoom call or the same email thread, even saying, all right, here's our patient. What do we all think we should do? Let's have a good discussion. Everybody brings their piece to the discussion, but everyone also speaks a common language of understanding what we're trying to accomplish. And then it's just a push and pull of, the orthodontist is wanting to make this movement happen, but the oral surgeon's like, well, actually, if you do that, you're not going to leave me enough room for my implant here. Whatever it is,
man, we
can have, if you could have a collaborative discussion, then it takes the dental school model, which at least was hopefully authorities you could go to and say, hey, this is the authority on something. Well, what if you could take all the authorities, have everybody in the same room in some way, and we could all have the same language that we're talking. I think that we see that as possible. We see that as not that far out of the realm, but it does have to be. That's a curriculum that we've never seen. It
takes humility, and it takes a very, very humble approach to the care of the patient. And everybody has to be calibrated, and you have to be prepared to agree on etiology and diagnosis. And right now, just like you said, we're just now seeing the data come out on some of these strategies on what's going on with people and their problems. Yep. And I'm excited. I think that, listen, if you're looking to start your journey somewhere in a calibrated way to be able to communicate to a specialist, because listen, if you take this course as a first step into understanding, how to communicate to patients, to specialists, just taking this course alone is going to put you light years ahead of most people that are in your realm as far as like when you graduated and that type of thing. You're going to have an idea. Now, being able to implement it, that's for another day, and we're going to talk about that probably next week a little bit about how.
But I will say, one of the cool things that they talked about, and like you say, we're going to cover this, there was a lot of time spent during this course on implementation.
That's right.
And I can see the concerted effort happening there at Spear to try to say, okay, so you learned all this.
What do you do next?
How do you actually, implement this? Because But the main thing is the vision that you get.
Mm-hmm.
The main thing is the vision. You come out of this and you feel like, all right, I have a vision for where things need to be and where things need to go and what my end result can be. Because we all know that's really what treatment planning is. Now that we understand it, is it's not working from all these different people and then you figuring it out from the back end.
Mm-hmm.
It's here's where we're going. All right. Can everyone agree that this is where we're going? Okay. If we can all agree this is where we're going, then all I got to do now is figure out how to actually do the procedures, or who do I refer to, or who does what part, and what's step 1 through 10.
Yep.
If there's one, the biggest problem up until we took this course was that we didn't always know where we were going. We just started doing stuff because we had this problem or that problem. And we wanted to, at least we were like, well, I know how to fix that because we were limited just by what we knew how to do, but we didn't really know where to start. Now, if we get to this, okay, we know the end, where we're going, now we can get everybody plugged in. And that's the power of this. And I think you hear it in the passion of what Gregg and Jeff are trying to do. We see it, and it is so cool to get to see it. And a lot of these docs were new, relatively young, and to see them get to already become influenced by that way of thinking, it gives us it's a really fun place to be, Wes.
I love it.
Because you see it all around you, and you see people and they're talking and they're excited and they're like, okay, this is what I've kind of been missing. And that's pretty cool.
It's pretty cool. Hey, listen, if you're listening to this right now, 865-544-8954, text the Dental Guys if you're interested in taking a next level course like this from Spear Education. You want to start your journey the right way, 20% off. Head over right now to the link in description below. Put in the code Dental Guys, get 20% off. Listen, that's like $1,200. We're paying for a little bit of your flight and maybe one of your nights stay out there. Hey, it's a next level course, and that's what we're about here, is taking it to the next level. Are you looking to take your practice to the next level? Hey, you've tuned into the right place, the Dental Guys. We've been around for a while now talking about this. We're doing it in our practice. We're about doing better dentistry. Listen, thank you so much for listening. Like, subscribe, all those things. Facebook, we're still on there. Instagram, X, let's go. Thank you so much tonight for listening to the Dental Guys. For Jon, I'm Wes, and we are the Dental Guys.